Clear? So everyone actively participate in the chat box, actively participate in the discussion, and let's make the discussion interactive. Clear? Is audio video fine? Can you update? So the MCQs which were there in the ENT segment were on the easy side, but they have asked you very simple, straightforward PYQs, previous year topics were there in the MCQ, and when we were trying my best to use this platform to predict the next NEET examination, NEET questions which are expected in your next examination. Everyone, can you update in the chat box? Is audio video fine? So as we have discussed in the marathon, आपको याद होगा बेटा, in the 2 days before your INI examination, we conducted our marathon session where we highlight the important point. And you remember I gave you two important things. One is carcinoma, larynx, and one is your blocks. They are very important topics for your central institute. So let's start with the first MCQ, that is your MCQ on CA larynx. Question was on CA larynx, beta. Clear? And what is a key word which was given by the examiner was fixed vocal cord. Now, this seems to be a controversial MCQ. Why? Because many students in the Telegram group or on my inbox message, they were saying that inner perichondrium of the thyroid cartilage was involved. Hardly make a difference, beta. Even if the inner perichondrium is involved, that is the tumor is confined within the larynx. So if you remember, we have revised the classification multiple times in the classroom as well as in DVT. T1, T2, T3, T4 A and T4 B. If you remember, T1 was within the larynx, one area is involved. If one area is involved, one subunit is involved, we call it as T1. And if 2 or 3 areas are involved, we label the patient as T2. This is something we have learned. If you remember the DVT session where we have learned paraglottic space, pre-epiglottic space, paralysis of the vocal cord, the fixed vocal cord is the important presentation. Patient usually come in the OPD with fixed vocal cord and we label it as T3. I hope you're confident of this point. T4A is something the tumor is going to the tongue, trachea. If your tumor is going up into the base of tongue or down into the trachea, so we always say tongue involvement, trachea involvement. That is your T4A, and T4B is the involvement of carotid artery or chest. The tumor is going into the chest, carotid artery. This was the basic classification we have learned. The examiner have given you paraglottic space. Everybody should reply. What should be the best answer here? Answer is should be T3 now. Clear? T1, T2 is ruled out. T3, and all the choices were straightforward. They have not confused you in the nodal status or in the metastasis. Done. So this CA larynx, very important, carcinoma larynx. I will be taking a couple of minutes to give you the important expected MCQ for upcoming NEET examination. So they will ask you your TNM classification. They will be asking you the management part. So be confident in carcinoma in situ. If they ask you in carcinoma in situ where basement membrane is not invaded, we use CO2 laser. Very simple, straightforward. In T1, T2, because partial laryngectomies are having many complications, we avoid the partial laryngectomy. Therefore, we prefer radiotherapy as a first line of treatment. Basic funda. T1, T2, the first line of treatment is always radiotherapy. Why? It have many complications. T3, T4, always remember that T3, T4 is a safer area where the treatment is laryngectomy. We remove the larynx with radio plus chemo. But now if the patient is not interested for the surgery, or we compare the age of the patient with the prognosis and all those points, we can go with concurrent chemoradiation. That is a simple basic funda. So in T1, T2 single modality is used, and T3, T4 we are having total laryngectomy with radio and chemo. But if the patient deny, or if we feel why to go give a surgical trauma to the patient, so better treatment will be concurrent chemoradiation. That is a basic funda we have discussed in the classroom. Is it clear? So what is the best possible answer for the management part? T3, T4 multiple modality. Now T1, T2 the first line is radiotherapy. Partial laryngectomies are rarely done, but you should be confident that horizontal partial, vertical partial, horizontal partial we prefer in the supraglottic tumors, and vertical partial is the surgery which we are doing in the hemilarynx tumor if the tumor is confined to one half of the larynx. This is one. So examiner have three options. Either he will ask you the TNM classification, or he will ask you the management part, and where is the third area, he will ask you rehabilitation. So what is the concept of rehabilitation? Patient, we will go for lifelong, he will be having tracheostomy tube because we have to remove upper part of the trachea is closed. Now you people tell me, lifelong he will be having tracheostomy tube. Patient will be breathing from this tube, and we will put a small prosthesis between trachea and esophagus, what we call it as tracheoesophageal prosthesis. Anyone who can write in the chat box, what is the use of this prosthesis? This prosthesis is for vocal rehabilitation. So for the last 2 years, they are asking the MCQ on post-surgery. They are showing you some opening on the antewall of larynx, and then they ask you, okay, which surgery was done in the patient. Always remember, if you see a larynx patient is there and there is a permanent tracheostomy done, we have done total laryngectomy. I hope you are getting my point. Yeah, after partial laryngectomy, we are not making permanent tracheostomy. It is only after total we are doing permanent tracheostomy, and there is a prosthesis. So every student revise with me on the antewall of trachea. What we are putting? We are putting tracheostomy tube. What we are putting on the posterior wall? A prosthesis between trachea and esophagus. Is it clear? What are the important terms? You should be confident. One is Blom-Singer, that is the oldest one, Blom-Singer tracheoesophageal prosthesis, or they can give you PMGE voice button. There is one PMGE voice button which can be used for rehabilitation. One is the latest, we are using Pervox. Okay, and the important concept which you should remember, as for tracheoesophageal prosthesis, it is on the posterior wall. And one important, electrolarynx. So what we are doing now, this is a PYT, previous year topic for you for the next upcoming NEET examination, and we should be master of this topic. So what is your tracheoesophageal prosthesis? For the vocal rehabilitation. Electrolarynx is not an internal device, it is an external device. The MCQ was there. So electrolarynx is a device to give some voice, is an old method. Is it clear? Once they have asked you something on polite yawning, so this concept they can ask you in the NEET examination. What is polite yawning and why we are doing polite yawning? So always remember, polite yawning is for your olfactory rehabilitation. Polite yawning, olfactory functioning. So we ask the patient to yawn with closed mouth. When the patient yawn with the closed mouth, there is a olfactory refunctioning. So this is something dedicated to the first MCQ we have discussed. Question number 2, often repeated, beta kai baar repeat hua. There is nothing new MCQ. Your high frequency documented loss, patient was having some hearing loss on audiometry PTA. The patient was having high frequency involvement, and if high frequency involvement is there, which part of the auditory pathway was involved? So definitely he's asking you, all the options, 4 options are from your cochlea. So he's asking you which part of the cochlea is involved, and we have already learned the base of the cochlea give high frequency. They are responsible for receptors is for high frequency, and the apex is for low frequency. So base, the option C will be the best answer in this MCQ. Is it clear? Now if you go in the depth of this line diagram of this cochlea, so always remember we have 3 important membranes with it. Upper membrane is Risner's membrane, lower membrane is basilar membrane. Basilar membrane is dividing your scala media from scala tympani, and Risner's membrane is upper one, that is your scala vestibuli from scala media. Is it clear? Now in this scala media we are having our organ of Cotta A. Here is my organ of Cotta. Is it clear? This is my organ of Cotta, and the upper part of this organ of Cotta we call it as tectorial membrane. So just remember, I want to make you familiar with the important terms which examiner have used. what I always say in my lectures, beta, this is a expected MCQ for next NEET. Now, stria vascularis, you should be master. What is stria vascularis? Stria vascularis is the highly vascular lining of the scala media. This one, they can give you a image line diagram of cochlea and they can ask you the parts. They can ask you what is this red highlight area is your stria vascularis. What is the importance of this structure? Importance of this structure, it is responsible for endolymph secretion. So beta, try your best to just do dissection of all the options. Beta, outer hair cell at the apex is responsible for low frequency. At the cochlear base, it is your high frequency. Very important. And tectorial membrane is a gelatinous mass of organ of Cotta. In organ of Cotta, there is a gelatinous mass which is known as tectorial membrane. So answer here will be option C. I will again take it as one of the easiest question, often repeated MCQ. और मुझे पूरा विश्वास है बेटा आप लोगों ने क्वेश्चन को गलत नहीं किया हुआ. First two MCQs, very simple, straightforward. The third MCQ they have taken from your ENT with radiology integrated MCQ. They have shown you something in the vicinity of your mastoid posterior part and they ask you which canal is this one. So this was a integrated question of ENT with radiology and four options were aqueduct, internal auditory canal, external auditory canal. One thing is damn sure, which option cannot be there? It cannot be external auditory canal. So it can be either your internal auditory canal, or it can be carotid, or it will be vestibular aqueduct. What is the importance of this internal auditory canal, which I am showing you in the slide? And the image may be different, but the message I got from the students, they have asked you on the internal auditory canal, and you should be confident of all the important structures. They can either ask you about ossicle, and what we have learned in the middle year, we have one convex ossicle, that is malleus. So if examiners show you, now just try your best and just try to learn this concept. If the malleus is very prominent, what we have learned in the classroom, short process. Short means concavity. If they show you something, a prominent area, that is your malleus. And if they show you something concave, that is your incus part. And if they show you something alphabet C, that is your ossicle. And ossicle's stapes will be always close to the inner ear. So we can identify here, this is upper part, this upper part. Can you appreciate better this part? Now just try to learn what I want to share with you. This is upper part, epitympanum. Yes, where we have Prusek space and most common site for any pathology. And this is your mesotympanum and the lower part is hypotympanum. Very simple concept. Now, this must be your external auditory canal. Can you appreciate the movement of the cursor, beta? And I'm confident everybody listening to me, this area must be external auditory canal. Now one student will say, sir, how we learn that this is your lateral and medial side? So just remember, this is your cochlea. Focus your eyes on this cochlea segment. If you focus, it means this area must be my inner ear. So here must be external auditory canal outside. I hope you're getting the concept, beta. Can you update in the chat box? Is it clear? Yes, beta. Even if it is inner outer, but now listen carefully. Your low frequency, high frequency, we are talking with a reference of base and the apex. Is it clear? So even if they have mentioned the word inner, so no worries for that. Clear? Now, can you appreciate the movement of the cursor, beta? What I want to explain you, this should be your bahar wali canal, external auditory canal, and the inside will be the internal. I hope you're getting my point. So if you concentrate the outside, bahar, next to its middle ear, if this room is taken as my middle ear, next to middle ear will be your somewhere your external auditory canal. Is it clear? Crystal clear concept? Is ये समझ में आ रहा है बेटा? ये चीज समझ में आई है? Now, if we go into the middle ear, we are taking one by one all the important concepts. Head of the malleus, you should be able to identify the convex structure. This convex area should be your malleus. Just try to appreciate this one. This is malleus, and next will be incus. If you go with the antrum, now what is antrum? Antrum is your mastoid segment. Mastoid segment. Is it clear? And if you go deep inside, this area is my inner ear, and just beneath, just next to inner ear, what we have learned, the auditory pathway, next to cochlea is your cochlear nerve 8 nerve, which is moving into internal auditory canal. So what the examiner have asked you, they have asked you this canal. I hope you are getting the concept. Ye samajh mein aa raha hai? Are you getting this segment? So this is here internal auditory canal from anterior to posterior. If you say this is my inner ear, I take the inner ear, here must be cochlea and then followed by saculoventricle, and the most posteriorly here must be semicircular canal. Thumbs up in the chat box if you are getting this basic anatomy. I am trying my best to give you all the important. Now next time when this question came, it can be outer or inner hair cell of the base of the cochlea, beta, base of the cochlea. Clear? Everyone kindly update, kindly thumbs up in the chat box. Are you able to identify malleus? Convex, beta. Incus, long process, it is concave. Antrum in ENT, antrum is used in mastoid, antrum is used in mastoid as well as your maxillary sinus. And utricle and posterior semicircular canal, they are most posterior. So just try your best always whenever you want to label. Everyone listening to me, kindly update in the chat box. Is this clear, beta? Yes, Dr. Ashish, very good. Thanks for the. Dr. Shweta, can you update in the chat box? Always try your best. I always highlight this point. Focus on the mastoid. You focus on the mastoid. This mastoid will tell you this is the posterior part, because it is very difficult for MBBS student to locate all the structure. That's why I am trying my best to give you labeled structure so that you should be able to identify in the examination hall. So always start from the mastoid. And if this is mastoid, it means this must be the most posterior part. And what is the most posterior part? Posterior semicircular canal. I will take it as posterior semicircular canal. Next is utricle, and this is cochlea. And what is next to this is your internal auditory canal. I am repeating again with all my students listening to me. This is your mastoid. Start from the mastoid. Then you will be appreciating your posterior semicircular canal. Then it will be utricle, and medial near to the brain will be your internal auditory canal. Internal auditory canal. Is it clear? Again, the better image I am showing you now. Just next to posterior semicircular canal, if I take this now, you know how to identify the posterior semicircular canal. It will be very on the posterior end, very close to the medial end of your mastoid, posteriorly. Here will be lateral canal. This is a favorite question of your NEET examiner. Always they ask you lateral semicircular canal. They are next to medial surface of mastoid, and the posterior canal will be just next to posterior canal. This area is your aqueduct. This area, this segment will be your aqueduct. I hope you're getting my concept, clear? So I can say, if I combine these two images, I can say my aqueduct is posterior, is slightly behind internal auditory canal. If the students get, why the examiner have given you close choices of vestibular aqueduct, because vestibular aqueduct is somewhere, it is posterior to your internal auditory canal. Is it clear? Crystal clear? And then this image will help you. I am just highlighting my aqueduct is very posterior, a vestibular aqueduct on one side. I am showing you a normal aqueduct. On the other side, it is dilated aqueduct. What is aqueduct? Aqueduct is a communication between the inner ear and bony part of the inner ear into the subarachnoid space. That is your CSF. It is responsible for peri-lymph secretion. So now I am confident, beta, you can identify malleus, you can identify incus, you can identify mastoid, you can identify utricle. Medial to utricle and cochlea will be your internal auditory canal, and external auditory canal will be absolutely lateral to tympanic membrane. That will be your outside your middle ear. Clear? Is this concept clear? Done. So these slides are very important for your upcoming NEET examination. Which of the following audiometry is not? Coming to the next MCQ. Thanks for all the update in the chat box, beta. Let's make the session interactive. Which of the following audiometry is not advised in the infant? सबसे easy question, beta. इससे simple question कोई नहीं पूछ सकता. Pure tone audiometry, PTA. I ask my patient, whenever he get the sound, he will raise the finger. So how can you do in an infant? Infant will not be following your command. So PTA is not very old MCQ. This question कई बार आता है. Audiometry mandatory. Always remember, beta, in your upcoming NEET examination. Now देखो beta, INICET exam is over. Now our target should be the next NEET. Even if we couldn't perform well in this examination, no worries, beta. That is the past, gone. Now we should plan for the upcoming NEET examination. And just remember, do mastery of audiometry. One MCQ from subjective, one from objective, mandatory, आना ही आना है. And I always tell my students, audiometry, you should be able to revise in 15-20 minutes. 20 minutes, the whole audiometry, basic audiometry should be on your tips. Pure tone audiometry, all the 10 graphs of PTA should be on your tips. Speech audiometry, you should be confident of rollover phenomena. You should be confident of tuning fork test, Riene's, Weber, Schobach, absolute bone conduction test. You should be confident of high frequency audiometry, Aati. Objective, one MCQ from subjective, one from objective. If I ask you to better revise objective audiometry with me in 1 minute, can you revise, sir? Conductive deafness, it is impedance audiometry. What is impedance audiometry? It is a combination of tympanometry with stapedial reflux. What is a battery of investigation for middle ear? What is electrocochleography? I am keeping a probe on the promontory and I am just taking the potential, summating potential of cochlea, action potential of 8 nerve, and BERA, brainstem evoked response audiometry, is something for neural deafness. So your basic concepts should be on your tips. With a multiple time revision, I always say, if you revise the things 4 times, you will be able to crack this NEET or INI examination very comfortably. Focus on the revision part. For those students who couldn't perform well in IA, no worries, better. Now work hard, revise. Don't add the points, better. It's better to revise. Now, line diagrams, keyword, like this is a very nice image which will help you in an infant. Which are the important tests we can do? We can do autocaustic emission, yes. We can do ABR. What is ABR? Auditory brainstem response. I can use for the word BERA, B-E-R-A. We use the word ABR. Behavior observation audiometry. I'm appreciating the behavior change of the newborn or infant. I can do. In toddlers, we are doing visual enforcement audiometry, autocaustic emission, BERA can be done. So this group of investigation is done here up to 2 years. Like between below 6 months, I am preferring autocaustic emission, BERA, behavior observation audiometry. Between 6 months to 2 years, we are doing all these visual reinforcement. OE can be done. BERA, autocaustic emission and BERA, they are screening procedure. They should be done as soon as possible, because if the newborn is having any deafness, we should treat the newborn as soon as possible. But the PTA, pure tone audiometry, it comes around 4 to, some books mention more than 4 years, some books say more than 5 years. Better to go with the 5 year, more than 5 years school going age. We are doing pure tone audiometry or tympanometry, all those things are required. Between 2 to 5 years, we can go for conditional orientation reflex audiometry. These are the audiometry we are using in pediatric patients, beta. So this image will help in the examination hall. I will advise you can draw infant, preschool, and then old kids. So this way we differentiate. I hope you are getting my point. So in this MCQ, the answer should be here: pure tone audiometry. PT was easy question, was not difficult. Clear? So coming to the next one. One question was, this was nice MCQ. I appreciate the examiner who made this question. Choose the most appropriate order of the endoscopic surgery steps. Very nicely format. I dil se appreciate the examiner ko. If you open the workbook, I have given you the concept of uncinate bone. And on uncinate bone, below the line diagram of uncinate bone, if you remember, we have drawn a line diagram of lateral wall of nose. In the middle meatus, this is your nasolacrimal duct. In the inferior here your sphenoid sinus open. Here is my posterior wall. Here is my uncinate bone. If you remember the line diagram we have drawn in the classroom, below that line diagram we clearly mention most common step, earliest step in endoscopic surgery is uncinate bone. Unless you we will not damage this area, we will not go behind this area. How can you identify all the structures? ना पढ़ा था, याद है? इसके पीछे जाना है हमने. We have to go behind uncinate. तो uncinectomy should be the first option. I hope you're getting my point. So in the recall session, even on the Sunday, we have discussed this point, art of ruling out. Now, how to attempt this question? Even if you have not done endoscopic surgery, this question doesn't mean, beta, इस question का ये मतलब नहीं है कि mug up all the steps of endoscopy. MBBS student, as a MBBS student, we should apply the common sense. Now, what we have learned, the first statement I always teach in my lecture on paranasal sinus, sphenoid is very posterior superior. We always highlight this point. I make my students write on the top of the page, sphenoid is posterior superior to nasal cavity. It means that in this question, I can appreciate these posterior ethmoidal cell and sphenoid. They are posterior part. They are the posterior part of the nasal cavity. It means they should be the first step or last step. Everyone should reply in the chat box. Everyone should reply in the chat box. If sphenoid and posterior ethmoidal air cell are in the posterior part of the nose, they should be the first step or they should be the last step. So they should be the last step. I hope you're getting my concept. So option A and option 4 cannot be the earliest. They should be the last step. I hope you're getting my point. So like sphenoid sinus, this should be the most posterior. So I will be searching where is sphenoid sinus most posterior and where is uncinate bone opening the uncinate is the first. So in the fifth, this is the first option. I hope you're getting my point. How to crack these questions? Sphenoid should be the most posterior. Sphenoid should be the most posterior and uncinate should be the first step. So option number 5 should be the first and your option number 4 should be the last. 5 should be the first, 4 should be the last. Even if I'm not confident of the remaining option, we can clear. So answer will be going in the favor of option A. Option A. Is it clear? Is it clear? Done. So option A. I will first go for removing the uncinate. I will be going behind uncinate. Then we appreciate the maxillary sinus ostium. This is the next step. Then we are entering into your ethmoid, where we open the biggest, largest air cell. What is the largest air cell? Dr. Ashish Beta, reply. Which is the largest air cell? Lowermost halar, largest bulla ethmoidalis. So we will remove the infected part of your air cell. The number 2 will be there, and then it will be your posterior ethmoidal cell, and finally it will be your sphenoid. It will be sphenoid. So these are the important steps for endoscopy. Then one MCQ was, let's discuss one more MCQ. This was on the block. If you have attended the ENT segment 2 days before your INI, I highlight this point in my marathon session. Okay, blocks are the important MCQ topic for your Central Institute. Always remember, clear blocks are very important. And the choices were very easy. Option were the greater palatine, nasociliary, maxillary, infraorbital. Maxillary and infraorbital will be, they will be giving you some image of the face or sublabial. We are giving the incident, but here they are giving on the palate behind. So what the MCQ was taken from this segment. Always remember, this is nasopalatine nerve, greater palatine, lesser palatine, which are supplying your palate. These 3 parts. So the answer will be going in the favor of greater palatine. This major chunk of the palate is supplied by greater palatine. ENT, sometime rarely we use this, but in those patients who are not responding to epistaxis. But yes, usually this is something ENT with anesthesia integrated MCQ. Very true, beta. Very true. Minimum 4 revisions required. This INA examination have proved the statement ke until unless will not revise. Just go with the qualitative learning. Your note should be very concise. I always say my ENT note should not be more than 15 pages, where must-read topic should be there, and you should revise multiple time. In my test and discussion, in the DVT session, all these blocks, this block they're asking for the last 2-3 years, beta. What is anterior ethmoidal block, also known as nasociliary block? If they show you this type of image, and if they show you this type of image is known as supraorbital supratrochlear block. 2023-22 they have asked you these questions. One is your infraorbital, very simple. One is infratrochlear. This is again very important. Our upper part, this segment, if you give the block, it is known as your infratrochlear block. So these were the important MCQs on the block. Again, beta, let's revise these important block. This slide is very important for again NEET. What I'm doing, which procedure I'm doing, nasolacrimal duct. Either they will ask you in ENT or in ophthalmology. Nasolacrimal duct patency. This is your supraorbital, also known as supratrochlear block. This is infratrochlear block. This is infraorbital block. Then one is your this supraorbital supratrochlear we have already learned, and this is anterior ethmoidal. This question was repeated multiple time. Clear? Then the last with the MCQ which was there, this question is very important for now upcoming NEET examination. So it is a greater palatine. So these were the important topics, important MCQs in your ENT. The motive behind this session to give you a message: make your ultra concise notes. Don't have the phobia of anything missing. 1 or 2 MCQs will always be out of the box. Don't run behind those questions. Work hard on the PYQs, PYT sessions. Revise them religiously, beta. Religiously. Apply the common sense. Step of endoscopy have proven that if you apply the logic, common sense, you can attempt all the MCQs. Best of luck, best wishes to all the students, and work hard irrespective of your performance in the last INI. Let's work hard for the upcoming NEET examination, and the whole DAMS family is with you. Attend all the sessions which we are conducting for revision part and revise multiple times. Best of luck, best wishes.